Hi, welcome everyone to the Neurocritical Care Society podcast. This is the Perspective series. I'm your host, Dr. Nicholas Morris from the University of Maryland Shock Trauma Hospital. And today I have the absolute pleasure of interviewing Dr. Matthew E. Fink. Dr. Fink is currently the Lewis and Gertrude Fale Professor and Chairman of the Department of Neurology at the Weill Cornell Medical College and Neurologist in Chief at New York Presbyterian Hospital, Weill Cornell Medical Center. He trained at the Neurological Institute of New York, Columbia Presbyterian Medical Center, and served as chief resident under Dr. Lewis P. Rowland. Subsequently, he joined the faculty of Columbia University and became the founding director of the Neurology-Neurosurgery Intensive Care Unit at the New York Presbyterian Hospital. Dr. Fink was a founding member and chairman of the Critical Care section of the American Academy of Neurology and the research section for neurocritical care of the World Federation of Neurology. He's board certified in internal medicine, neurology, critical care medicine, vascular neurology, and neurocritical care. He's been a pioneer in education and research within the field. Welcome, Dr. Fink. We're very happy to have you on.
Well, thank you very much for inviting me. I am delighted to be able to share some of my experiences in this field with those who are listening. It's been a fascinating ride for me, and I'm happy to talk to all of you about it.
Great. Well, we'd love to hear about it. So why don't you, if you don't mind, start by taking us back to you had trained at Columbia, you stayed on his faculty. There was no ICU, neuro ICU back then. What were you doing at that time, and what led you to actually get this neuro ICU off the ground?
Yeah, well, I'd like to go back actually earlier than that,
Oh, sure.
if that's all right with you. I decided in medical school that I was going to go into a field that had something to do with the nervous system. Many of us had those discussions. I didn't really know what I was going to do, and so I took electives in neurology, psychiatry, neurosurgery. Ruled out psychiatry, ruled out neurosurgery. It's interesting because later in my career, I was actually invited to join the residency program in neurosurgery at Columbia. The chairman asked me to switch residencies, and I had to tell the chairman of neurosurgery that, I actually find it very boring to be in the OR for all those hours. Not, he looked at me like, are you crazy?
Yeah, I had the same experience. I remember I tell residents this now, or some of the medical students, that the first neurosurgical case I ever saw was one of the most incredible things I'd ever done. The second one, about 4 hours in, I was ready to move back to neurology.
Yeah, exactly. Same experience. But when I was in medical school, I also did an anesthesiology elective. And my mentor was someone I didn't know who he was at the time. Some of you may know the name Peter Saffer. Peter Saffer really was the founder of the Critical Care Society and one of the leaders in the field. And I spent several weeks with him, one to one, as he taught me how to do intubations and a whole lot of other critical care procedures that he was an expert at, and I didn't even know I was being taught by the world's expert in this. But it clearly had an impact on me. So when I decided to apply for residency, I knew I was going to do neurology at that point. I came to neurology from what I consider to be a medical orientation as opposed to a psychiatric orientation. I think people go into neurology with one of those two orientations. Either they're sort of intrigued by the behavior, and that's the psychiatric orientation. Mine was medical, so I decided to do more medicine before neurology. So I signed up to do 2 years of internal medicine first, but I ended up doing 3 years of internal medicine because I really loved it. But everything I did in internal medicine, I always referred back to what was going on in the brain. I saw patients with heart failure. How's that affecting the brain? I saw patients with pulmonary infections. How's that affecting the brain? That was always my orientation. So I came to Columbia as a resident in neurology, and we had a huge inpatient service, about 180 beds, and everything that smelled like neurology from the emergency room got admitted to us. And we had an incredible variety of stuff. Some of it probably not even appropriate, but so what? And Bud Rowland, who was my chairman, had a world reputation in neuromuscular disease. And so we had a huge number of patients who came to us with myasthenia gravis, ALS, other kinds of neuropathies, myopathies. And some of these patients, as you know, get really, really sick, and they get intubated, they go on ventilators, and particular myasthenics are treatable conditions. And what happened to me as a resident, I was a second-year resident. I was on call one night, and I got paged, a stat page in the days when we had pagers, a stat page to see a patient who turned out to be a 24-year-old woman with generalized myasthenia gravis, intubated on a ventilator in a single room on a regular patient care floor with a bedside monitor. And the bedside monitor started beeping, and an excellent nurse got there as soon as possible and realized that the patient was not being ventilated properly. So I got stat paged, went to see her, realized that her endotracheal tube was obstructed. We took out the ET tube, reintubated her, and thought we had solved the problem, but she had been hypoxemic for a prolonged period of time. And she ended up with secondary hypoxic ischemic brain injury from which she never recovered. 24-year-old healthy young woman with a treatable disease. And this, in my view, this happened because she was not in a properly monitored setting. She needed to be in an ICU. So why was she not in an ICU? Because at our hospital and at many hospitals throughout the United States, throughout the world at that time, patients who had such severe neurological problems that they needed to be in an ICU were simply rejected by the medical and surgical teams who were responsible for this. And they would literally say to me, if they're that sick, we're not going to be able to help them, and you may as well just give up. And in reality, what happened to patients who had, whether it was trauma, stroke, neuromuscular disease, severe infection, status epilepticus, all of those patients, when they were really critically ill, they were not treated in a proper intensive care unit. So for me, this was a pivotal moment. You know, the light bulb goes on, and I'm saying to myself, we need our own ICU to take care of these patients. So I went and talked to my chairman, who had the same view of this and had been trying in his career to do the same thing, but was never able to get support from the hospitals that he worked at. And before he came to Columbia, he was the chairman at the University of Pennsylvania. He tried it there. Nobody would support him. At Columbia, nobody would support him. So he said to me, I want you to give a presentation to the faculty at a departmental meeting. I was chief resident at that time, but I was still a resident. He said, I want you to give a presentation to the faculty and tell them what your concept is and what your plan is. And I did that. I got in front of all the faculty and I presented the argument for why we should have our own intensive care unit so we could take care of our patients. If our mission was to do the very best for our patients, then we needed to have an intensive care unit, take care of them ourselves. And I presented this, and then one by one, at least 10 different faculty members stood up and attacked me, demolished me, said one after another, this is the worst idea I've ever heard. This is stupid. This is terrible. Neurologists should not be doing this kind of thing. We're not going to support it. And there was universal rejection of the proposal. Not a single person stood up in support of what I was going to do. Not a single person. Now, so I listened to all of this, and fortunately, I didn't take it personally. I just realized, here's the problem. Here's the problem. So when the meeting was over, Bud Rowland said, okay, Matt, come into my office. I want to talk to you. So we went to his office and he sat me down And he said, okay. He said, what's your takeaway from that meeting we just had? And I said, my takeaway is everybody hates the idea. Nobody's going to support it. And he said to me, you're right. That's exactly what we heard. He said, but let me tell you something. He said, the best thing about being the department chairman is that I can ignore what everybody else says if I want to, and I can just make an executive decision to do this, and that's what we're going to do. We're going to do it.
Wow. Wow.
And he said, I'm going to hire you to do it. July 1st, this is going to be your job. He said, however, it looks like you're doing it all by yourself. I don't hear that there's anybody in the department that's going to help you with this. So that is how I got started. Now, so where did I do it? Well, we had a neurosurgical recovery room. The neurosurgeons had a recovery room in the building, and that was the only place we could do this. We were going to have to share it. Well, how was I going to get the neurosurgeons to work with us on this? Because it needed to be a multidisciplinary program. So I really didn't know. I had good relationships with the neurosurgeons because I worked with all the residents closely. And as I said, when I was a second-year resident, the chairman of neurosurgery, Bennett Stein, who actually had just come to Columbia at that time, I took care of a lot of his patients. And he invited me at one point to switch residencies. And it's kind of funny because my wife to this day says, oh, you should have been a neurosurgeon. You would have made a whole lot more money. and I'm like, nah, that's okay. I made the right choice. So I got to know him very well. So what did I do? Well, I started just hanging out in the neurosurgical recovery room, getting to know the nurses, going around, seeing the patients, and just getting a sense of what we needed to do in that particular unit. And the nurses were delighted to have me there because there were no other physicians in that unit. The surgeons were in the OR. There were no doctors around. It was the nurses, and if they ran into problems, they didn't know who to talk to. They couldn't, surgeons in the OR. So I was hanging around there, sort of helping out, being, available to help when they had questions. And while I was there, one of the post-operative patients, I believe it was a post-op aneurysm clipping, day after surgery, for whatever reason, had a sudden cardiac arrest. Never knew why. I was there, and with the nurses, we pulled the team together and we resuscitated the patient, got her back in perfect shape because we immediately started treatment because she was, the cardiac arrest was diagnosed instantly, treated her, got her back. It turned out that this was one of Dr. Stein's patients. So later that night, he came out of the OR. And he came into the ICU. The nurses just briefed him, told him what happened. And he was like, oh, my God, what happened? But they said, oh, no, we got her back. We resuscitated her. Dr. Fink was here. He helped us out. He organized the team. Went great. Your patient's fine. So the next day, Dr. Stein calls me into his office. And I didn't know exactly what he was going to say. And oddly enough, he didn't say, thank you very much for saving my patient. He didn't say that. He looked at me very intently and said, I get it now. Those were his exact words. He said, I get it. I now understand what you're talking about, what you want to do, and why it's important. And from that one incident, he became my greatest supporter through all of this, and continued to be for all the years that I was there, one of my greatest supporters. And if it wasn't for that, we would not have had a fully integrated multidisciplinary unit. He understood the fact that we as neurologists, being in the ICU all the time, could make a huge difference taking care of not just our own neurology patients, which was an obvious thing, but also the neurosurgery patients. So we, from day one, got involved in taking care of all of those patients. Now, I had to do it myself, and I tell everyone, for the first 3 years, I was on call 24/7 for 3 years, literally. I was in the hospital 7 days a week. I made rounds 7 days a week. I was taking phone calls until I could finally start to build my own team, because none of the existing people wanted to work with me. So that was the start of it. So I had support from the two chairs, chairman of neurology, chairman of neurosurgery, and that was the start of it.
That's an incredible story. I want to ask you a little bit how you started to build your team, but before that, you'd mentioned sort of the nihilism in the medical and surgical ICUs. What did they think of all this as you're coming up with this idea of a neuro ICU and getting support from the neurology and neurosurgery chairman? How did that play in?
Well, I think that their first reaction was, "Oh, great, you're not going to bother us anymore about trying to get your patients into the medical or surgical ICUs." That really was their initial attitude. But shortly afterwards, they started to appreciate what we were doing. And within a relatively short period of time, I had anesthesiologists who wanted to participate. That's how we build a team. I got a really good attending anesthesiologist who said, "Wow, this is great. I'm really interested in this stuff. Can I, join the team?" Internal medicine, pulmonary medicine people, cardiologists. We gradually developed a whole team of people who were interested in neurological disorders. And it went from being, "Oh, we don't want to have anything to do with these patients," to, "Wow, this is really cool. We want to be involved."
Right. And were you able to recruit in those early days other neurologists to the neuro ICU?
Yes, actually, the first person I recruited was Laura Lenahan, who's at Columbia. She's the vice chair at Columbia, and Laura was a resident in medicine at University of Pennsylvania, did her residency in neurology at Columbia, then was a stroke fellow. But she was, to be polite, she was marginalized as a stroke fellow. And I attribute it to the fact that she was a woman, and the stroke team was a bastion of males who, like to make jokes that were inappropriate, and she was ostracized and never felt part of that team. And I observed it, and I knew that she was a brilliant, well-trained physician in both medicine and neurology. So I spoke to her when she was finishing her fellowship. I knew she was miserable, didn't know what to do. And I said, "Would you like to join me and be one of the attendings? I need the help. This is exactly what you're good at doing." And she was delighted to do it. And so she was my first attending who really helped. And then we started developing a fellowship, and then we started building the team really from the ground up.
Right.
We also got an anesthesiologist who joined the team as well. As I said, he volunteered. He said he was a neuroanesthesia attending who wanted to do neuro ICU work.
And Dr. Lenahan still remains very involved with the ICU now, and in how she has run the graduate service they have there at Columbia.
Absolutely. Yes.
That's great. I can't help but go back and talk to you a little bit about Peter Saffer, because we haven't talked about him on this podcast. And I don't know that neurointensivists, especially young neurointensivists, really know who Peter Saffer is and how important he is in critical care. And to have someone who trained with him, I think he's inspired, dozens at least of intensivists. What was it about Dr. Saffer that it sounds like from a very early point in your training really inspired you to follow this ambition?
Yeah. Well, again, I didn't know anything about who he was. I was simply assigned to him for a period of several weeks, and I worked with him every day. I went to the operating room with him every day, and he taught me to do all of the procedures to prepare a person for surgery, and that included putting in lines, learning to do endotracheal intubations. To this day, I can still visualize Dr. Saffer telling me how to do an endotracheal intubation. And I haven't actually done one myself in a number of years, but I could do it, at this moment, and I can still visualize it. And what was so remarkable about him is that, and it's what I really love about neurointensive care as a specialty, he was very much oriented towards physiology. And everything he taught was always based on the physiology of why he was doing what he was doing. And to me, that was just the most amazing part of it. He didn't do anything with the statement that some people, say, oh, well, that's just the way we do it. Remember that phrase, that's just the way we do it. He never said that. He always explained it based on what the physiology was about, why he would, do a particular technique during intubation. There's always a good reason for it. And I just love that. And I found that when things were explained based on physiology, I remembered them that way. I don't know how other people remember things, but for me, it was a great way to remember what was going on. And I didn't know he was such a prominent person. He developed in Pittsburgh, he started a separate department. They have a department of critical care medicine, which is a very, very prominent, prestigious department. And he really created the whole field. And he was a lovely man, just a really nice guy. I was just fortunate to be assigned to him by chance.
Yeah, and I've been lucky enough to learn from those who learned from him, and that's really been an honor. And for those of us who don't know Dr. Saffer and what he's really, in many ways, the father of resuscitation. And if you have some time, you better YouTube his videos where he kind of shows us all how to ventilate patients. He anesthetized or paralyzed medical students in order to show the power of bag valve mask ventilation. And he's really, really, in many ways, one of the true pioneers of critical care. But
yeah. And he had a difficult time in his own career when he first came. I believe he immigrated to the U.S. I think he came from Eastern Europe, and started out doing his research at what was then Baltimore City Hospital in Baltimore, where he was studying resuscitation and the best way to do CPR on dogs. And then Hopkins picked him up. Realized that he was a brilliant guy doing brilliant research, and a wonderful man.
Okay, so let's go back to the Columbia ICU there. And how did you go from this imprint of this neurosurgical recovery area, which I'm sure was not quite so large, developing what in many ways is one of the very first well-established large neurocritical care units with a faculty and fellowship? Can you take us a little bit more through some of those small steps?
Well, we worked with this limited area in the old Neurological Institute building, which is still there, which, by the way, was built in 1930, I think 1932 or something. It's an old, decrepit building. When I was working there, it didn't even have air conditioning. There was no air conditioning. The plumbing that wasn't working. Amazing that we were able to do anything there. So we started working in this old recovery room, building a team of physicians, working collaboratively with the neurosurgeons. And the one message I'll give to anyone who is interested in developing this is, it is critically important to have a strong, positive working relationship with the neurosurgical department. It is essential. If you don't, you will not be able to do this. And I was lucky enough to have it happen in one fell swoop by resuscitating that one patient. But you got to do it. You have to work at it, and you have to work at it because otherwise you can't succeed. So we built a team, and what happened was it became widely recognized throughout the New York metropolitan area. And I say metropolitan area, that's 100 miles around New York City, that we were able to take care of critically ill patients with terrible neurological diseases, patients with ruptured aneurysms, neuromuscular disease, status epilepticus, serious neurological infections, and the surrounding hospitals were unable to do that. They couldn't do it. And pretty soon we were flooded with referrals from all of the surrounding hospitals who didn't know what to do, didn't have the knowledge, didn't have the technology. For a long time, we were the only service that could do plasmapheresis. Nobody else could do plasmapheresis. So all of the patients with Guillain-Barré and myasthenia who needed plasmapheresis got shipped into us. And we were flooded. And the hospital all of a sudden became very alert that, oh, look at this. Look at all these new patients that are being transferred into us from all these other hospitals. They all of a sudden started to pay attention to this. Like everything else, money talks. So the hospital saw this as a big revenue generator for them. And then when they planned to build a new hospital, which is what they did, we were included. And part of that plan then became a brand new dedicated neurological ICU in the new hospital. And that's how we were able to then move from this old building into a brand new unit that I helped to design at the time. And we moved into that unit in 1991. It was a Saturday when we were physically transporting patients from the old building across a bridge into the new building. I was in there. I had all of my team and all the residents who were in there moving patients. I still have a T-shirt from that day that I saved. Everybody got T-shirts, moving T-shirts. And we moved into a brand new intensive care unit, neuro ICU, in 1991. That was a very big day for all of us. And it was the only one of its kind in the whole region at the time.
Yeah. It's always struck me when I look back at the early research that was coming out of the neurological ICU at Columbia, that it really is a collaboration between neurosurgery and the neurologist. You wouldn't really know in any given paper. It could be Robert Solomon, who's the first author. It could be Laura Lenahan. It could be you. And you were all sort of interested in the same things. Can you talk a little bit about the research mission and how important that was in those days?
Well, it was something that went part and parcel with the treatment that we were trying to provide to patients. And let me give you an example. And a lot of it was never published. A lot of this stuff we just did and not published. But for example, early on, we recognized that one of the greatest failures in aneurysm surgery was delay in surgery, that the standard routine at the time was to wait several weeks until the patient was, quote, stabilized, or the surgeons used to use the term until, quote, the brain cooled off, whatever that means, before they wanted to operate. Well, what happened during those 2 to 3 weeks was about half those patients had their aneurysm re-rupture and they died. And so we made a decision that we had to make a dramatic change. And how did we make that dramatic change? Well, we pulled together all of the attending physicians in neurology and neurosurgery who were involved in aneurysm patients. We got them all together in a room, and we all agreed, let's sit down and come up with a new protocol that's going to change this. We all recognize that what we're currently doing is not working. It's not working, and let's change it. And we did it in a consensus conference. And then we literally on one day, and I think it was a July 1 of I forget which year it was, everyone agreed that if a patient came in with a ruptured aneurysm, unless there was a real contraindication, if they were grade 4 or 5, they were going to go to the OR within 24 hours to get their aneurysm secured. And this was before the days of endovascular therapy. This was all going to be open surgery. And so the people who were doing it, Bob Solomon, was a new attending neurosurgeon, and he was an expert in aneurysm surgery. He did the lion's share of these cases, and he was, operating 24/7 on these patients. But we all agreed that this is what we were going to do, and it dramatically changed the outcomes of these patients. And now, as you know, with endovascular therapy, every patient gets treated as immediately, even if they're grade 4, grade 5. Their aneurysm gets coiled, gets treated, with all of the new devices. So we were able to accomplish the research because we recognized there were so many problems that had no good answers, and we did it as a team. We always would get together as a team, and it was always a collaborative team of both neurology and neurosurgery. Always. We always did it together.
Well, so much of what we learned, or what we have learned in subarachnoid hemorrhage and beyond, really did come from the Columbia Neurological ICU. How did you go about building the research infrastructure there? Because I was a fellow there, and I've always been impressed by.
When were you a fellow there? What year were you there? When?
Oh gosh, 2014 to 2016. Yep.
Okay, so I was at Cornell.
You were at Cornell there,
yeah. Yeah. Okay.
But really, it's churned out so much knowledge over time, and that's not true across our field. And it really stands out as sort of a beacon of research, and has for a long time. It strikes me you were pivotal in building the infrastructure. So what steps did you take to do that?
Well, at the time that this was going on, I had no strategic plan of what to do. Okay. I was really building things one day at a time, one piece at a time, as we needed it. But the key was to get the right people together, who had the same mission and the same goals. And then we had to hire, there was no research infrastructure that we could rely on. There wasn't anything. So we just had to gradually start hiring people, piece by piece, begging for space, and begging for support, to do that. I think it's a lot easier now because most departments of neurology have a strong research infrastructure. So at Cornell now, I've got a whole team of research coordinators supervised by a physician who's an expert in doing these things. And so anyone who wants to do a clinical research can take advantage of this team to help them. But back then there was no such thing. And so we just had to gradually add it on piece by piece, until we had it. And it was done independently. It wasn't from any help from the department or from the medical school or from the hospital. We just had to do it ourselves. And we recognized that this was the future of our field, and we had to be innovative.
As I'm listening to you, I can't help but think that, of course, you've become a chairman and gone into administration because you were doing that from day one. You were basically, you've told the story of being a founder of a startup company. And can you tell us a little bit about how your career has transitioned beyond kind of the 24/7 clinical care to being a department chair?
Yep. Well, let me just make a comment about the startup company. I think that's a good analogy. I love to take on new things that others have not done before. For me, it's an exciting thing to do. I've turned down job offers. I was offered a job in the 1990s, actually, to go to one of the Harvard hospitals in Boston. And I thought about it and considered it, and I rejected it primarily because the bottom line was the person trying to hire me said, "Oh, I want you to come to Boston and do the same thing that you did at Columbia, New York." And that was an immediate turnoff. I don't need to go to another place to do the same thing, right? I mean, why would I want to do that? I want to do something new and different. So after about 10 or 11 years of working in the ICU, building the ICU program at Columbia, I was offered a new opportunity to build and create a multidisciplinary neuroscience service at one of the other big hospitals in New York City, Beth Israel Medical Center. Beth Israel at the time, this was in 1994. Beth Israel was actually the largest independent hospital in New York. It had 1,400 beds. It was a behemoth, a huge place, not particularly academic. It was affiliated with Mount Sinai academically, but the leadership decided they wanted to create a neurological program that would compete with the other places in the city. And what that was, they wanted to develop everything: neurology, neurosurgery, neuroradiology, interventional, I see everything, the whole thing. And they basically recruited me and hired me to do that, to build a completely new neurological service based on what I thought were the best things to do and recruit the best people. And that's what I did. I took the job and I started recruiting people from the whole region in all of these different areas. And I got some of the best people, mostly from New York City. I sort of, poached people from all of the big academic medical centers, brought them together. They built a brand new facility for everybody. And within 3 years, the volume of patients we were bringing into that new center was only second to Columbia at that time. I mean, we very rapidly increased the volume, and it was all based on bringing in excellent people who were all working together. And so oddly enough, after 3 years and showing success, the chairman of the board met with me over lunch, invited me to his office for lunch, and completely out of the blue said to me, we're looking for a new CEO of the hospital, and we think you would be great at doing that job. So they actually offered me the job to become CEO of this hospital. And again, in the way I think about things, I saw it as another great opportunity to do all sorts of new things. So as a complete shock to my, friends, family, and colleagues, I said, all right, let me give it a shot. Let me see what it's like to be a hospital CEO. So that was never expected that, but it all grew out of the work that I did. First the ICU work at Columbia, then building a neurological service at Beth Israel. And then based on that, they asked me to be the CEO, saying, look, if you can do that with all the neurology programs, the neuro programs, can you do that with all the other programs? And I started to work on that. Now, it didn't work out quite the same. If you've kept up with what's going on, Beth Israel was taken over, completely taken over by Mount Sinai, which is, proceeded to dismantle it piece by piece, and it's the entire hospital is going to close in another year. But that's the way it goes sometimes. But it was an extraordinary experience while I was in that position. But as you can see, it was not something I wanted to pursue. I could have gotten another job as another hospital CEO. I had no interest in doing that. I wanted to get back to my roots, really.
So back to your roots, back to neurocritical care. As you look back over the last several decades, what really sticks out to you as the biggest breakthrough or the thing that's changed the field the most?
Well, I think that minimally invasive catheter interventions have been, in my view, the biggest breakthrough that we've had within our field. I think that has been huge. That's been a huge area. And just as an aside, when I was a neurology resident I kind of knew that was going to happen. I tried to get into a INR fellowship as a resident it was in 1979, I guess. I could not get any place in the entire United States to accept me as a neurologist. Nobody would accept me, which is interesting. But so that turned out, I think, to be one of the greatest breakthroughs ever in terms of what we're doing. And it's not just for stroke. I mean, it's going to apply to, treatment of brain tumors, disruption of the blood-brain barrier, to treat a whole bunch of other things. So I consider that to be the greatest breakthrough in our field.
I remember at my time at Cornell and Columbia, the mobile stroke unit was just getting started. And I think that was really your initiative. Can you talk a little bit about the mobile stroke unit and what it's meant to Cornell?
Oh, absolutely. Absolutely. I learned about the mobile stroke units on one of my annual trips to Europe. We run a course in Austria every year in Salzburg. And whenever I go there, all of the attendees are from European countries. And I started hearing about what was going on in Germany, in Hamburg, where it was really first started around 2012. And when I came back to the U.S., I found that Jim Grotta in Houston was starting a program in Houston. And I really thought this was a phenomenal idea, that the concept of going out into the field and diagnosing and treating a patient in the field was the way to do it, because you were going to save a lot of time and you were going to definitely have a big impact. I presented this multiple times to our hospital leadership. They all looked at me and said, yes, this is a great idea. It's a great idea, but there are lots of great ideas.
And this one's an expensive one, right?
Yes, this is an expensive one, but who's going to pay for this? We don't have money in the budget to pay for this, even though it's a great idea. And it was unproven too. I mean, it seemed like it was going to made a lot of sense, but it was unproven. So it meant somebody's going to have to take a chance. So I went back and forth multiple times. And then finally, what did it was a donor, a member of the hospital board who heard about this and spoke to me about it, really also felt that this was a great idea, and he supported it. He was going to support it. So he made a gift of, several $1,000,000 for us to get this program started. And I spoke to Jim Grotta about it. Jim came up as a sort of a consultant to help us with it. And then we went ahead and had the first unit built. The more difficult problem was getting the New York City Emergency Medical Services to support it, because there's a single EMS service run by the fire department in New York. And the political issues with that were quite difficult. I spent many, many hours, many meetings talking to them to try to get them on board, because the mobile stroke unit program had to be integrated with the EMS services that were taking 911 calls and triaging ambulances. And that was a very, very difficult thing. But we finally were able to get it. And we got the first unit operating in 2016. The first year, we went out physically, all of our stroke doctors, including myself, we went out on the ambulance runs in person. And for me, it was one of the most eye-opening experiences I've ever had, going out with the EMS workers. The first thing is I was impressed, amazingly impressed at how good they were. They were really, really phenomenal. And, having to, run up 10 flights of stairs with a full backpack, and go into somebody's apartment, which, you don't know what you're walking into, and having to address these acute emergencies. It was incredible. And I've said to many people, if I have a heart attack and, need emergency help. I want the EMS people. I don't want a doctor. The EMS people know more than the doctors do about what to do. So for the first year, I went out with others. We went out on the ambulance runs, and it was an exhilarating experience. We learned a lot. And then after we got the procedures down to be really, really fast and efficient, after that 1 year, we converted to telemedicine, because long term, you can't have a stroke neurologist spending their time riding around in an ambulance. It just doesn't work. So we converted to telemedicine, which worked just as well. We had a nurse on the ambulance, and then we were fortunate enough to get additional support, and we built 2 more units. So we had one in Manhattan, we had one in Queens, we had one in Brooklyn. As you know, we incorporated the Columbia team as part of it. I did that from day one. I felt it should be a system-wide program, that it wasn't just a Cornell program. It was a New York Presbyterian Hospital program. I wanted everybody to participate. That's always my mantra, get everybody, under the tent to get these things done. And it went extremely well until the pandemic hit.
Mm-hmm.
And what happened, the effect of the pandemic was that there was a critical shortage of emergency medical techs, of EMTs. A lot of them got sick, a lot of them quit, and we had to redeploy our paramedics to regular ambulance runs. So we put the program on a pause for about, I guess it was about 1.5 years. Then we started back up again. So it's running again, but we only have 1 unit. And the results are being published. I don't know if you've seen the results. And there's a new paper that's coming out very shortly, showing the economics of it. And the program overall saves money for the whole healthcare system. The problem is the way we are reimbursed. The hospital, we have to provide the upfront, pay the upfront costs. The savings go to the insurance companies and the Medicare program. They save money. The hospital has to spend money to let the insurance. So they're happy to let us.
Of course.
You know how that works. I mean, it's in Europe, it doesn't work that way. In Europe, the government is the single payer. Mm-hmm. And so they recognize that they're going to save money. So the government there supports it. So we're trying to get CMS to change the rules and at least reimburse us for the work that we're doing. But I happen to think the mobile stroke program is superb. I wouldn't rank it up as the most important success we've had, because unfortunately it hasn't been expanded. It's been very limited. It could be an incredible benefit to society if we can roll it out to, all of the metropolitan areas. Right. But until we can do that, it's going to be sort of a boutique kind of program. So let me just mention one other thing, because when I came to Cornell, we did not have a neuro ICU program at Cornell. It was very limited. But one of my former fellows, Stefan Mayer, was running the program at Columbia at the time. And I called up Stefan and I twisted his arm, basically. I said, Stefan, we're going to build the program here. I'd like to do it together. I want to do it together. So let's expand the fellowship so that Cornell and Columbia can do it together. And it was rocky for the first few years. I don't know if you experienced any of that yourself. Initially it was rocky, but it has turned out to be a phenomenal success. And the fellows have great experience at both campuses. And I think it's, without question, the best fellowship program in North America at this point. So I'm very happy with the way that worked out. That was a great success.
Well, I certainly had a fantastic experience, and I thought it was really valuable because there were actually institutional differences between Columbia and Cornell, and to get to experience that as a fellow, I think was really important for my training. So I certainly appreciated that. I I think we're coming up on time here, but I've been impressed in your career. You've really been an early adopter, and kind of seen things before they happened. What are you seeing on the horizon that excites you in neurocritical care or emergency neurology?
Yep, sure. Well, I'll tell you that oddly enough, the one area that I am really hot on right now, and I'm trying to get our hospital to buy into it, I think the concept of hospital at home is the next big thing that we should be pursuing. That I would say that, half the patients who we admit to the hospital from the emergency department these days could be cared for at home if we had the right support services, monitoring, and I think all of the technology we have can allow us to do that. And the hospitals then are going to be essentially intensive care units and operating rooms, and virtually everything else should be done at the person's home. And so I'm very, very focused on trying to get people to start looking at hospital at home, and that applies to stroke patients as well. I mean, yeah, they have to come in, get thrombolytics or thrombectomy, but most of those people, after 24 hours of observation, could go right home and be, managed at home. And I think there are a lot of similar situations like that. So that's the area that I think is going to be the next big area, hospital at home.
That would be very exciting. We were rounding last week in the ICU. We had an older woman with some cognitive impairment who was admitted with a very small intracerebral hemorrhage. I mean, minuscule. And sort of not surprisingly became wildly delirious in the ICU. And
yes,
sooner or later she was in restraints in a posy, developed urinary retention every day. Was kind of worse than the next. And part of me just thought maybe she just would have been better if she never came in.
Yeah. Well, let me give you an act. When I was a resident at Columbia, we used to rotate to Harlem Hospital. Okay. And in those days, 1970s, the services at Harlem Hospital were so bad that when I was the consulting resident, I got called to see a stroke patient in the emergency room. I would sit with the family and I would tell them, look, this is not a bad stroke. I'm going to tell you what to do. And I wrote down, this is what you're going to do. I want you to take your mother home, take care of her at home. You're going to do these things, because if we admit her to the hospital here, she has a higher probability of getting sick and dying in the hospital than if you take care of her at home. And I used to send all these patients home with instructions to the family about what to do. And I think in many ways, we're going to be getting back to something like that.
Yeah, I sure hope so. Just to finish up, we do a few kind of quick hit questions with everyone on the podcast. And these are sometimes fun. What other passions or hobbies do you have outside of neurology?
Well, before I got into medical school, my primary activity was I had a rock band.
Oh, really?
And I almost didn't go to college because my band was going to go on the road, and I wanted to go on the road with them. I mean, so that was my primary, and I love music. Music is my passion. I've got 5 or 6 guitars and basses sitting around, unfortunately collecting dust that I need to get back to start playing.
Very interesting. You share the name with a famous musician, don't you?
Oh yeah, Dr. Matt Fink, who was the drummer for Prince.
Yes.
Yes, he was the drummer for Prince at the time. And yeah, and people have Googled my name and keep coming up with him. So
yep. It's funny he goes by doctor as well. It
yeah,
really
and he's not a doctor, but he wears scrubs. He wears scrubs when he plays in concerts and stuff. Yeah. I found that pretty interesting. Yeah. I don't know. I'm curious to know why he developed that
I have no idea. Maybe it's just to show you your sliding doors experience. That could have been you. As I lose my voice here, what other specialty would you like to have attempted or to attempt?
What other specialty? Well, as
you mentioned IR, but
INR would have been the other area that I was going to go into. The other area that I was extremely interested in, I still am actually, is movement disorders, and I love movement disorders just because of the focus on understanding brain circuits and neurotransmitters and things like that. And we had in the ICU for a while, we had a whole bunch of patients with Parkinson's disease because there was a fad at the time of abrupt drug holiday. So all these patients were taken off of their levodopa, and they all developed rigidity that was so severe that many of them had to be intubated and put on ventilators. So that was a big mistake to do that.
Yeah. And what specialty would you not like to do?
Would I not like to do? Still, I would not want to be a psychiatrist.
Yeah.
I haven't changed my mind about that.
No. Is there a sound or smell in the ICU that you really like?
Well, I lost my sense of smell
Probably for the
completely
better.
in 2009. I had a bad bicycle accident. That's my
wow.
other passion. I'm a big biker. I do a lot of biking. Had a bad bicycle accident and a head injury. I lost my sense of smell, permanent. But I have memories of having some. I had, my biggest memory is I had a terrible allergic reaction to a perfume that one of the ICU nurses used to wear in the ICU all the time. And I remember talking to her. I was very embarrassed. But when I went up to her, when I said, I apologize for saying this to you, but I'm having a terrible allergic reaction to whatever kind of perfume you're wearing every day. So I don't want you to take this the wrong way, but could you try to not wear that perfume because I'm allergic to it? And she was fine, actually. She was like, "Oh, that's fine. Don't worry. That's okay. I'm not offended by it." But you got to be careful about those things.
No, absolutely. And then to finish up, what advice would you give to a fellow who's about to graduate?
Well, it's the same thing I say to just about everybody. You need to follow your passion of what you're really, really passionate and interested in doing, and don't worry about what's the next job is going to be. Focus on doing the absolutely best that you can do with what you're doing right now today, and I can promise you that fabulous jobs will come your way in the future if you do a great job today. Don't worry about what you're going to do next. There's too much anxiety around that.
All right. Well, thank you so much, Dr. Fink, for spending some time with us. We really appreciate it. For all the listeners, please check out the Neurocritical Care Society podcast, available wherever you get your podcasts, including Spotify and Apple. CME are available, and we hope you tune in next time. So thanks again, Dr. Fink, and we look forward to what you do next to lead our field.
Thanks for the invitation. You be well.
Bye.